research that she's doing in pediatrics. And that for me speaks a lot to who Amy is. Amy is passionate, but also humble. Amy is amazing. I am privileged to call her one of my colleagues. Amy, I know we realized yesterday with shock that you've been at it for 10 years. Yeah, but you see, it never dawned on her that she's been involved in research for so long because she loves what she's doing. So it gives me great pleasure to introduce Dr. Amy Slogrove, who will be speaking about building bridges between maternal and child health. Amy, the floor is yours. Thank you.
Thanks very much, Lindsay and Ian and the organizing committee for the opportunity this morning. It's really a privilege for me to get to share a little bit of what we're doing and why we feel it's important, particularly with this audience of people who I really think all of you are partners in this. Even if I don't know you yet individually, I think we're all in this district and in this setting particularly focused on improving maternal and child health. And it's an incredibly tremendous honor to follow Nilda and to be able to speak in the same session as Nilda. Nilda and Rob have been tremendous sort of, without being structured mentors and guiders over the years, and was just a delight to hear your story this morning, Nilda. Thank you. So I'm going to be talking about mostly research in this session. And I'm going to be talking about maternal and child health, but with saying maternal and child health, I really mean maternal, newborn, it's now become child, adolescent health, and actually I mean sort of the whole spectrum of health over the lifetime. But I'm just, for brevity, going to refer to maternal and child health. And I'm going to be sort of emphasizing bridges, as a theme throughout, and building bridges. But what I really want to just say in the beginning, this is going to be focused on research, but I think all of us in our interactions with mothers, particularly in our interactions with the moms in relation to their children, have an immensely privileged opportunity to build a bridge with that mom, and to just let that mom know that we see her, we acknowledge her, we realize it's tough for many of our moms on a day-to-day basis, and that she's actually doing a good job. And I don't think moms hear that or feel that they hear that enough within the healthcare system. Within the province and this district, particularly the first 1,000 days, being from conception to the end of the second year of life, are a particular focus. And I'm going to look at why this investment is so important in these first 1,000 days, but why we should now start to be looking even beyond this period and broadening our vision. And part of this is related to the growing awareness that actually when a woman is pregnant with her child, she's actually already influencing her grandchild. There's more and more evidence coming out that when a woman is pregnant, particularly with a girl child, in that embryo and in that fetus are already the egg cells, the ova that are going to be that mom's grandchild that is going to develop from her own child. And we're starting to, there's a body of evidence building around how important the grandmom's pregnancy and what happened in her pregnancy actually is on her, not only her own child and their life course, but on her grandchild's life course. So maybe in a few years' time, we'll even be talking about maternal and grandchild health. And so I really want us to just broaden our vision this morning. And so a bit of a wake-up call within the last decade has been the story of Diethylstilbesterol. I'll just abbreviate it as DES. And this was a medication that was marketed and promoted for preventing miscarriage and preterm labor, and was given to millions of women who had previously had a miscarriage or previously experienced preterm labor to try and reduce this risk in them, something we all desperately want to try and avoid in pregnant women, miscarriages and preterm labor and the consequences of those. And it was only many years later that it was found out that the daughters of the woman who took this DES during pregnancy had a 40-fold increased risk in very rare types of cervical and vaginal cancers and double the risk of breast cancer. And since then, more evidence is accumulated that even in these daughters of the woman that took DES, their daughters have had a greater risk of birth defects. And there have also been effects recognized in the sons and grandsons. But really, this story tells us that we need to be thinking far more long-term about what the positive and negative influences are on a pregnancy, and positive and negative exposures during pregnancy. And the only way we can really link what's happened to a pregnant woman to her children later down the line, or even maybe her grandchildren, is if there is some kind of record link that tells us that this mom received this particular medication or received a particular intervention. So we really need a bridge between the mom's history and all her experience and exposures to understand what influence this is having on her children and even her grandchildren. So we really need to take this much longer term view. I'm a pediatrician. Very much for most of my career so far has been focused on the first years of life. And for myself, I've realized that if I really want to actually impact on society, community, I need to be moving out of my comfort zone. Even though I really do not like working with adolescents, and I really now do not like working with adults after many years of being a pediatrician, I need to start really thinking hard about how are we going to understand these early life influences. There's a lot of buzz around this first 1,000 days and what this investment means, but how are we really going to understand how to maximize this investment unless we figure out ways to study these influences and these exposures over time? So I'll bring our focus now a bit to specifically within South Africa, and just thinking about a number of prevalent pregnancy exposures in South Africa. So we know that we have this double burden of disease, infectious diseases as well as chronic diseases in our country, and pregnant women are not spared from this. So we see in South Africa now around 22 to 23% of all pregnant women are HIV infected, and they're all on antiretroviral therapy now. These are exposures to the developing fetus and to that baby. There's a substantial proportion of pregnant women on TB treatment during pregnancy. There are women who have chronic diseases, neuropsychiatric conditions, diabetes that don't go away when they're pregnant. And then there are very high rates of detrimental social habits. So astoundingly, in a study in the Drakenstein, they found that 56% of newborns had nicotine levels in their blood that were as high as levels of smokers, showing that actually 56% of newborns were actually exposed to smoking, and the moms were smoking towards the end of their pregnancy. We know, we're very familiar in this area with how prevalent alcohol exposure is during pregnancy, and there's a growing awareness of the detrimental effects and actually the teratogenic effect of obesity during pregnancy, and more evidence around associations with birth defects as a result of obesity and the metabolic disruptions related to obesity during pregnancy. So I'm going to hone in a little bit on HIV for a while, and I just want to stop and have a look at these trends in South Africa in HIV in pregnant women. So the dark blue line shows us how from 1990 up until about almost a decade ago, about 2005, the proportion of pregnant women in South Africa living with HIV escalated tremendously. And now we've reached a bit of a plateau, actually for a number of years now, for about the last decade. We're about 22 to 23% of all pregnant women in South Africa are HIV infected. So I just pause there for a bit, because I think when you really stop and think about this figure, it's quite astounding that almost 1 in 4 pregnant women in our country is HIV infected. With that means that there's been this increasing in the lighter blue line proportion of all children born in the country that are HIV exposed, meaning that they're born to an HIV infected woman. And thankfully, due to the plummeting grey line, which shows the reduction in the number of children born to HIV infected women who are themselves HIV infected, this has been without a doubt one of the public health successes of this decade in the world and in this country, that only 2% of babies born to HIV infected women now themselves are HIV infected. But we've still got this blue line is the group of babies born to HIV infected women who are themselves HIV uninfected or HIV exposed uninfected children. And this means that at least 1 in every 5 children in South Africa is exposed in utero during pregnancy to a chronic viral infection, being HIV, and at least 3 highly active drugs now, the antiretroviral therapy. And there's never ever been an exposure to an infectious disease or to highly active drugs of any kind to this magnitude ever anywhere else in the world. And here we've got these 2 exposures together in the same group of children. Unfortunately, women living with HIV have higher rates of adverse birth outcomes, more stillbirths and more preterm birth. And this hasn't gone away with women being put on antiretroviral therapy. Even more unfortunately is actually there's evidence that women conceiving while on antiretroviral therapy have a higher rate of preterm birth than HIV-infected women initiating antiretroviral therapy during pregnancy. So I want to be very clear here. I'm not saying that HIV-infected women should not be on antiretroviral therapy. They absolutely have to be on antiretroviral therapy. It's the best way to keep the moms alive and healthy. It's the best way to prevent transmission of HIV to their babies. But we need to work harder to make that antiretroviral safer for moms and babies. And so what also particularly piqued my interest is that we know HIV-infected women have these poorer birth outcomes, and we know hypertensive disorders in pregnancy, preeclampsia, eclampsia, gestational hypertension, also cause more preterm birth, more stillbirth. And there's some evidence to possibly suggest, although it's not very good evidence yet, that hypertensive disorders in pregnancy are increasing in women on antiretroviral therapy. So I started to wonder, well, could this pathway from the mom developing hypertensive disorders in pregnancy be contributing to this problem that we have with high preterm birth and stillbirths in women with HIV, despite being on antiretroviral therapy? So I'm fortunate to be able to build on a study that was started by a team at UCT called Be Positive. And so our study is called Be Extra Positive. And we are within this study aiming to evaluate whether maternal hypertensive disorders in pregnancy and HIV are associated with adverse maternal birth and infant outcomes in the Western Cape. And so what I really want you to take from this diagram as well is that my interest actually for the last decade, as I realized with Lindsay yesterday, has been on the HIV-exposed uninfected infant and understanding why they're at increased risk for common infections in childhood and death. But I realized the only way I was going to figure that out was also if I stepped out of my comfort zone and started to better understand and better educate myself on what was happening before infancy, on what was happening in the neonates, and what essentially is happening in the moms. And so, as Nilda said, I think a lot of people are wondering, what on earth is a pediatrician doing studying now hypertensive disorders in pregnancy? But I've been able to build bridges and draw on support and the wisdom of many other people outside of pediatrics that are able to help and inform this work. So how are we doing this? It's going to be a cohort study that is made up of 2 parts, a province-wide cohort of all women delivering in the Western Cape province for a 2-year period. So that's about 180,000 deliveries. And in this cohort, we'll be looking at a very superficial level at whether hypertension in pregnancy is associated with HIV and these adverse maternal and infant birth outcomes. And then that's combined with 2 Sentinel site cohorts, the one being run by the Guguletu team, the UCT team, the Sentinel site at Guguletu, and the second site that we're busy developing here in Worcester, that will include then about 17,000 deliveries. And we're doing this in Worcester, actually with just this wonderful team of these 3 people, Heinrich, Johan, and Alicia, who are 2 data clerks and a research nurse, we're maximizing the routinely collected information that is so much effort is put into getting in the province on the paper-based maternity case records. Heinrich and Johan are digitizing this into a provincial data system called PHCIS that is then integrated through a provincial health data center now. We're very unique in the Western Cape to have all patients in the province with a unique identifier that can link them across multiple electronic systems across wherever they go for care in the province. And all of this information is actually now synchronized at the Provincial Health Data Center to be able to have this long-term view of an individual patient. So this photograph has come out terribly, but maybe that's actually, it was a bridge leading into the wilderness. And this is just to say that this unique identifier in the Provincial Health Data Center are really creating a bridge for us to understand potentially for the long term what early life outcomes are. Mom and baby identifiers are linked at birth. So as that baby grows and that person grows through the system, we'll actually always be able to go back and see who the mom was and what happened to her during her pregnancy or during her lifetime. And this allows us to build on this initial investment in collecting, digitizing this routine data and linking moms and babies at birth to potentially for the long term follow this course. So I've mentioned briefly all of these other exposures in pregnancy that we really don't know what all this is doing, adding together. And so if you want to know a little bit more about that and what we're doing in terms of establishing a pregnancy exposure registry and birth defect surveillance in the province, come to the parallel session number 5, and Alicia will be describing a bit more what we're doing with that. And then I really want to just end off with saying that it's about finding the balance. We need to find a balance between prioritizing moms and prioritizing children, and that both are equally important. And obviously considering with using this kind of routinely collected data, confidentiality of this data combined with balancing safety of understanding exposures for the long term. And this is to end off just a couple of other bridges that are in process of being built and under construction that I think are really novel and really highlight the uniqueness of Equanda is that there's been at least an intention and a willingness to speak between the Department of Health and Department of Education to collaborate on more improving efficiency of information transfer for learners with special needs from the Department of Health to Department of Education. There is an effort to develop a high-risk clinic that will, a neurodevelopmental, early childhood development high-risk clinic across university departments and including the Department of Health and the hospital in Worcester. And then, as Ian mentioned, the FAMCRU research unit that is particularly studying maternal vaccines for reducing early childhood common diseases. That is also sort of crosses the departments. It comes from the Department of Pediatrics coming out here to Worcester, and exciting things too that we'll hopefully be hearing more about in the future. So just to end off, I know I'm already way over time, but this is a tremendous amount of teamwork that's come together to make this possible, to start with this initial investment that we hope will be able to continue for the long term. And then just to particularly highlight gratefulness to funders that are funding this work. Thank you.
No. Okay, you are more than welcome to corner Amy during tea time.